Well, good morning, and I'd like to thank everybody for attending this presentation on our quality improvement plan here at Chaparral Regional Hospital. I just want to start off by mentioning that we've had some complaints in the recent past from both patients and staffing, and we want to implement this plan so we can address those opportunities to result in the best patient satisfaction outcomes and associate employee satisfaction also. Here we're going to implement some methodologies. We just want to talk a little bit about them. We have the PDSA, which is a plan, do, and study. Plan, do, study, and act. The approach is we're performing tests and to gain improvements repeatedly on a small scale basis. A little bit of an overview of the process. This is a problem-solving model based on 4 stages and is used for improving the process and implementing change. We're also going to look here at the lean methodology. It's just a waste elimination. It includes that. It maximizes value by improving flow and mitigating activities that have no value to the organization or to the patient. We want to maximize our human equity. That's our people. Our resources and energy of our organization directed towards creating the value for the customer or the patient. Six Sigma is another methodology. It's streamlining processes where variation is reduced or eliminated in the processes based on statistics and data, striving from continuous improvement and eliminating defective product, insufficiencies, processes, and services. We're going to look a little closer here. This is once again one of our methodologies and our models where we plan, do, study, and act. And we're asking those questions. What are we trying to accomplish? How will we know that the change is an improvement? What change can we make that will result in the improvement? Outcome measures. These are types of measurements for quality improvement. Outcome measures are a critical component of any medical practice, and of course here at our hospital. Outcomes are important in direct management of patient care and effectiveness of that care. Sometimes it's referred to the people's voice as it is an end result. It answers the questions, what are the end results of our quality improvement work? Our process measures. It intends to capture the changes, the changes the impact make and the quality improvements made, which is the inclusion of steps taken to correlate the system outcomes, sometimes referred to as the voice of the working system. It is paramount to be the process's centric measure, as it is what contributes directly to the desired outcome. We have the balancing measures, which is the understanding and determining the changes made for improvement in one area of the system that can contribute to inflate an existing problem in another area of the system. A prime example of this would be new quality improvement changes to increase patient satisfaction, but in turn it reduces the job satisfaction of associates. And the PSDA measure, which we mentioned, are those that are collected with each test of change. That measurement is collected and is carried out. This measure provides information about the effect of the change that we're trying to attempt. So we want to incorporate a survey to gauge and to measure data based on our patient satisfaction. And the overall design of the surveys have some components to it. I just want to briefly go over those components. We need to define who is the client and what do they value. We need to measure. How do we know what value is? And how do we measure the performance? We analyze what is causing deviations or defects in what we're doing. We try to improve. How can we eliminate or maximize these defects? And then we want to control it. How can we sustain those improvements? How can we make it consistent? To the right is a sample of our survey. It addresses certain areas of the satisfaction of our patients. And those areas are feeling heard. The patient feel like they're being heard and understood. Their pain, their level of pain, their aftercare, are they taken care of? The staff response. Is our staff responding in a satisfactory manner? Room satisfaction. When the patient's in a room, are they satisfied with the conditions of the room? Nursing satisfaction, their satisfaction with nursing staff and overall experience while they were here at our hospital. Statistics that we derive from this information are very important. We use a combination of statistics, some more than others. I'd like to briefly talk about those. First off, in proportions and percentages, they're commonly used for quality measurement. Most people can understand them easily. With a numerator represents the number of people or persons out of the total number of people, which is the denominator. For an example, to simplify, if you ask the question, were you satisfied with your overall experience, yes or no, the yes responses there, question yes or no. In the result, for yes responses would be 5 out of 10. If there were 10 people asked, 5 said yes. That indicates the response of yeses. Ratios, which are used less frequently, involves the estimate of the population as the denominator. It's an estimate. We have 100 people in our population, for example. The numerator, it's difficult for consumers to interpret the meaning of a ratio. For example, in a simplified term, 2 of 3, or 2 out of 3, they all mean the same thing. Pretend we have a class of 25 students. 10 students are boys and 15 students are girls. That can be magnified into hundreds and thousands. Means and medians. In healthcare quality metrics, they're rarely used. They're normally used for wait times if they are used, or phone hold times. For example, the mean wait time of 30 minutes. Does it indicate if it's better or worse? We really don't have a base. We just know that the mean or the average wait time is 30 minutes. And then counts. Simple, but effective. Counts can indicate adverse outcomes. This is without consideration of the overall population. And they are not utilized to compare facilities, but are observations within the organization. And they're utilized internally and not normally provided to the public. You know, we had 500 patients today. Very simple count. It's used internally. So as we move forward with our quality improvement program, we have to create a task force, and we have to identify who is going to lead that task force. The QI project manager. This position is a direct link to the senior management, navigates and project strategically. Supports the team by providing resources and assists with breaking through roadblocks. Holds the team accountable for the execution of the project and reviews the team process through team meetings, dashboards, and emails. An example may include our chief operations officer or a director of nursing, that kind of level. Besides that, we have the QI team lead. This is a proven leader within our organization with people management experience and known for developing, supporting, and coaching a service team to success. So a little bit of history with coaching teams. And process excellent analytical and process improvement skills. This is important that the person have influence over areas that are affected by the change. So a good example might be a middle manager or a program director for this type of position. Identify who should be on the task force. Quality measures are typically developed based on evidence generated through research and clinical practice, with most measures being as clinical guidelines. Developers of measurement could include clinical leadership could be involved on the task force. This individual has obtained authority to test and implement the change and to problem solve issues that arise in the process. The individual also understands how changes will affect the clinical care process and the impact those changes may have on other parts of the organization. We need to have a technical expert on our task force. This individual has deep knowledge of the process of area in question. A team may need several forms of technical expertise, including technical expertise in QI processes, health information technology, systems needed to support the proposed change, and specifics in the areas of care affected. A good example of this would be a team implementing an intensive care management clinic for people with poorly controlled diabetes might need technical expertise in change management and clinical electronic health records and the patient treatment protocols that will be used. Also on the team, we need day-to-day leadership. This particular individual is the lead of the QI team and ensures completion of the team's tasks, such as data collection, analysis, and change implementation. This person also must work well and closely with other members of the team and understand the full impact of the team's activities on other parts of the organization, as well as the area they are targeting. And of course, we have finally a project sponsorship. This individual has executive authority and serves as a link QI team and the organization's senior management. Although this individual does not participate on a daily basis with the team, he or she may join periodically and stays apprised of its progress. When needed, this member can assist the team in obtaining resources, overcoming barriers encountered when implementing improvements. Suggestions for implementing results of a survey. We want to spread and sustain the project improvements. So after all the data is collected, and we've identified changes that will improve and bring success to the process, it is important to spread, sustain the process to bring consistency and culture to our organization. There are 5 areas your team should focus on when spreading and containing our improvements. Involve and inform your senior leaders. Step 1, we need to ensure the senior management supports the spreading of the new concept and our new QI tool. Individual ownership is a key component. We want to identify who will first spread the change, a coordinator or a team lead. Hardwire in the improvements. Identify how change will be communicated to the staff via training, job performance, job descriptions, and criteria. You communicate improvements to the staff. Empower them to create accountability and buy-in. Own it. Accountable for the improvements. Every one of us are accountable for the improvements. And of course, we want to continually measure and monitor our results to ensure that the new process is still working. We want to make sure that we can sustain on the improvements that we make. So in conclusion, we just want to review a little bit. We talked about our quality improvement as a framework that we use to systematically improve the care that is being delivered to our patients. We're going to utilize methods such as PSDA, Lean, and Six Sigma. We want to create that satisfaction survey, and we want to derive statistics from the survey, and we want to implement and create a task force that leads the team and identify those leaders of the task force to implement the suggestions that we make. Once again, I want to thank you for your attention and your time on this presentation. This presentation will be forwarded to you in a hard copy that you could print out with a video link for your reference should you desire to refer to it again. Once again, thank you and have a good day.